In the asymptomatic setting, there have been a number of clinical trials done in the past 20 to 30 years looking at this question of whether or not outcomes can be improved by giving chemotherapy early on in the disease as opposed to waiting until things reach symptomatic state and beginning chemotherapy then. And this is a slide which is intended to show that patients who had either deferred chemotherapy versus early chemotherapy did not have any change in their overall long-term survival. Clearly, it's difficult to take asymptomatic patients and make them feel better by giving chemotherapy. So if your objectives for treating anybody with malignancy are either to improve length of life or improve quality of life, it doesn't seem that, based upon these data, that early chemotherapy that was used in these trials was able to do that. These studies are all quite old. It is a reasonable question in the era now of understanding this heterogeneity, being able to identify higher risk patients who might be destined for a poorer outcome, who might have a disease biology that can lead to more problematic mutations down the road, as to whether or not some of these trials might be worthwhile repeating with more effective treatments. And certainly this is something that has been attempted in North America, and certainly studies over in Germany, and may well be something to be looked at again in the era of targeted therapy. But as it stands in 2015, right now, regardless of the clinical or genetic factors, the standard of care remains the dreaded watchful waiting, which is a term that I know many of you can't stand, and it is a difficult time to be diagnosed with a malignancy and be told that we're not going to do anything about it except watch and wait until something bad happens, and that is certainly a challenge in the clinic. Coping with that uncertainty, coping with this issue of how do you apply average outcomes to what's going to happen to me, and this question that comes up: well, what should I do? What should I do during this time? How can I prevent something bad from happening? And I think this is something that we'll be focusing on in a specific psychosocial breakout session later in the afternoon. But it is challenging, and I think that really there has to be an individualized approach in terms of trying to obviously maximize and take the opportunity to optimize your health through lifestyle modifications, which can be very important. There may be the need for more supportive care resources through your doctor's office or cancer center, whether that be counseling or otherwise. Sometimes it can be really challenging to figure out just what this all means and how to deal with it. Clearly, it's important to not just to forget about other aspects of your health and regular follow-up with the family doctor. To deal with these other preventative and important other health measures is important. And I won't get into the issue of complementary alternative health products, but obviously that's another area that requires careful discussion, I think, with the practitioner. Is that right? I only have 1 minute? I apologize. Oh, okay. We'll try to, as I mentioned earlier, I won't spend too much time focusing on treatment. That'll be left for other talks. But just in very general terms, the management of untreated CLL has evolved recently, and I think that's evolved largely through clinical trials that have demonstrated the benefit of rituximab or monoclonal antibody therapeutic regimens pioneered through the MD Anderson and confirmed in large clinical trials, particularly through the German CLL study group, and this concept that clinical trials have often not been reflective of the general population of CLL patients, have often focused on patients who are much younger and much fitter than a lot of CLL patients may be, with average or median ages of the patients on studies often in the 50s or early 60s as opposed to the early 70s, like we know the disease is in general practice. And this idea, this understanding that some of the more aggressive therapies like FCR may not be as well tolerated or as beneficial in populations like that, and this move to specifically investigating those populations in randomized trials directly. So that's been, I think, an important shift, and one that you'll hear a little bit more about as well. And clearly in the management of relapsed refractory disease, there really is the beginning of a paradigm shift with the development and more mature clinical data of in particular B-cell receptor pathway inhibitors like ibrutinib and idelalisib, and the impact that they are going to have on the disease.